spine surgery, the process of doing spine surgery. So with that, let me just kind of reset. As a reminder, my name is Chet Donnelly. I'm a spine surgeon here in Dallas, Texas. I sometimes jump on here to do different spine surgery things, answer different spine surgery questions. Sorry, I'm trying to get my hat on a little more straight. With that, I'll go over different topics such as spinal stenosis. I'll go over different topics such as disc replacements, and we'll go over different topics such as spinal fusions. So if you have any questions on those, you can ask away. This is a spine model. So let's kind of just reset and kind of take our time going through the different anatomy. If you're looking at the spine, it's the same thing as a cervical spine. This is a lumbar spine model. It goes bone, disc, all the way down the spine. In terms of what causes the issue, bone, disc, bone, nerves come out under the bone. And when those nerves get pinched, they start shooting down the leg, shooting down the back. That's what causes radiculopathy or sciatica, both different terms for numbness and tingling or pain going down the leg. The reason you get that usually is from a condition called spinal stenosis, and that's what I was going to go over today. That's where, again, if this is your neck or it could be your lumbar spine, if you're looking down the tunnel, you have all the nerves running down the sac. Now, if it's in the neck, it's the spinal cord. Once it gets to the rib cage or below, it's just a sac of all the nerves just running down. So when those get squeezed, that's what could cause either heaviness in the leg, something called neurogenic claudication. That's a very common presentation. Patients with back pain, numbness and tingling down the legs, but when they start doing certain activities, they say it's almost like they get weights on their legs and heaviness in their leg. So there's usually three things that cause spinal stenosis or neurogenic claudication, and it's usually from one of these three things. First, it could be a disc herniation. So if this is the disc, it pushes out, starts squeezing, hitting the nerve root, squeezing the thecal sac in that area. The other thing could be is this joint degeneration. So these joints are rubbing kind of back and forth. They grow extra tissue that could develop into this canal here, causes spinal stenosis. The other thing it could be if you get something called instability or spondylolisthesis, where one bone is sliding forward. Those are kind of the three main causes. All right, I'm going to jump to some questions here. I see a lot of questions coming in. One saying RFAs, Maria, talking about RFAs. Maria, RFAs stand for radio frequency ablation. Many times spine surgeons don't do that. We have our pain management colleagues that do that. I'm looking for a pin. And what that would be essentially is when they can either at the facet joints or not these nerves you see, but smaller nerves, the pain management doctor, sometimes spine surgeon, can put a little needle, for lack of better words, that are hot, and they can burn either the nerves in the facets or the nerves kind of going right to the facets. That's what an RFA is. From JLP, they don't last. That's true. They do not last. Those nerves do regenerate. They do come back. But that's not saying they're not worth doing, because what if that buys you a certain period of time to get out of that flare-up? There are millions of patients that get either injections or RFAs and are able to avoid surgery, and that's a great thing. Spinal decompression did not work. What's the next step? From user, a bunch of numbers. Not sure. That's just a huge question. In terms of spinal decompression, talk about the surgical outlook, it could be going in through the back here and shaving off some of the bone spurs, taking out some of the thickened tissue. It's called the ligamentum flavum. That could open the nerves, make more room for you. Another question about RFAs from Zine, Ohio. Nerve ablations did not work for me. Facet blocks sometimes work. Yep. Well, kind of getting to those two questions, both from Kayla and Maria. When you define did not work, sometimes you say it didn't work even that first day, that first week. Or is it that you got pain a couple years later and therefore the ablations didn't work? Well, if it works for a couple months, couple years, then I usually consider that a good success. Now, is that saying, oh, it only works for a couple years, so you should just do surgery step one? No way. I don't like that idea at all. The argument that I use, the thing that I try to argue is that if you could use the different injections to diagnose the issue, as well as to calm down the irritation, that's a great way to have great success for spine surgery, and also a great way to identify which level is causing your issue. Yep, from JLP saying it only worked for a full year. Well, I want to go around telling people it didn't work, because if it worked for a full year, well, that's a full year of either less pain or no pain. So I consider that a pretty good thing to do. In general, the time I like using injections the most is when you have pinched nerves, either in the neck or in the lumbar spine. And Tommy, I'll get to that question in just a minute, because that's an interesting question. But the best time they work is if I'm not exactly sure, is that a L3 nerve that's pinched? Is it an L5 nerve that's pinched? Usually in the lumbar spine, there's kind of clear patterns. In the cervical spine, there's a little overlap. So one way I could use minimally invasive tools to diagnose the issue and then to subsequently treat the issue is working with one of my pain management colleagues. They put a little needle next to the nerve in question. They do an injection there. That injection, if it takes away your pain for a couple days, well, wish it was longer, but great. At least I know now I have a better idea of what's causing the issue. If it works for a couple of years, well, great. That just avoids another treatment for a couple of years. So those are kind of some of the ways that I use injections to hopefully get you better to diagnose it. I see a lot of questions coming in about disc replacements and fusion, so I'll kind of jump to that. But then I'd love to get to more some of the non-operative ways we can manage spinal stenosis. This is a older model of a disc replacement um, and how they work. So kind of be similar. This one's for lumbar for sure. But if it was in the neck or if it was in the lumbar spine, is here's what a normal spine model looks like. And it goes bone, disc, bone, and you have the nerves that come out on the side. Again, I appreciate all the likes coming through. That helps promote this to your peers that might be having similar issues. But again, here's kind of how the spine would stack up. Probably more accurate here because it's usually done at the lower part of the spine. When someone has, and there's many indications, I usually just stick to the FDA indications. I'm a very firm believer in FDA indications when it comes to spine things. That's how you maximize your outcomes. Also stick to society guidelines. But in general, I like to definitely argue that a disc replacement in the neck is totally different than a disc replacement in the lower back. The argument I use to my patients is it's almost like a hip replacement and a knee replacement. Most people at home would agree those are two totally different things, um, but they have some of the same similar concepts where they're replacing something. That does not at all mean that they're have the same biomechanics or the same outcomes or the same indications. And I usually just argue that to patients, just trying to educate them that the cervical disc replacements are totally different than the lumbar disc replacements. In general, both of them you have to go through the front, either the front of the neck or front of the stomach to get to this disc. These disc replacements don't do anything to the joints in the back. So if you have severe joint arthritis, both according to the NASS guidelines, North American Spine Society, as well as the FDA guidelines, that's not the most ideal indication for a disc replacement. The other thing we reference is the IDE, and that's pretty much when you're doing an experimental device. That's what they're first called. It sounds a little scary, but experimental device, they have certain strict guidelines. So a lot of people like to stick to those strict IDE guidelines in terms of how to get things done. So it goes bone, disc, bone. When you're going through the front, that's where you place this here. So again, bone, disc, bone. You take out this disc material here, and that's what you put in this device here. That's a great way to help it. Let me just pull up something here for you. So the next thing I'm trying to show you guys here is who is not a good candidate for a disc replacement. Well, there are three factors that make you not a great candidate for disc replacement. And this usually applies both in the neck and in the lumbar spine. Now, you'll find people out there for sure that will go against these guidelines, and that's okay. They're just guidelines to be fair. I'm not saying I know everything in the world about disc replacements. So, look, if someone's going against the guidelines and they're having good success, well, that's great. I'm a big rule follower, so I like to stick to the guidelines. But in general, there are three things that go against disc replacements. One is if you have severe bone on bone collapse. If you have severe bone on bone collapse here in the front, it definitely implies that these joints are taking all the weight, are taking all the load, and you have joint arthritis. Again, these disc replacements only fix the front. They keep this back part moving. So if you have severe back part arthritis, severe back pain, severe neck pain, well, you're still likely going to have that because it's rubbing around. The other thing is you have something called instability, spondylolisthesis. And I see the questions coming in. I apologize, Levy. I'm going to get to that just in a moment. But bone, disc, bone, if you have spondylolisthesis, one bone sliding forward, that is not a great indication for a disc replacement because it also implies severe joint arthritis. Again, are there people out there that still do it? Yes, I'm not at all criticizing their work. I'm just saying that's kind of the IDE guidelines that I follow. And the third would be if there is more than 50% disc height loss kind of coming down. Well, that likely is contributing to a significant degree of neck pain or back pain. in general, if back pain or neck pain is your presenting symptomatology, and you don't have the shooting pain, it's just a back pain or neck pain treatment, that's not the most ideal candidate also, because again, that could definitely imply joint arthritis. Um, from Charlie Weiser, I have a failed artificial disc. Charlie, I'd love to hear if that's cervical or lumbar. And again, I apologize to all those questions coming in. About 2,000 people in the chat, so they're coming hot and heavy. Jay saying thank you so much for sure. A lot of follows. Happy Hippie, thanks for the follow. From Marshall, my screw is loose in the neck. Love to hear why. What about extreme shooting pain? Again, a lot of questions coming in. I do apologize not getting to them. I'm trying to hit some of the highlights one. We kind of rapid fire questions here. So screw loose in the neck. Likely, again, not trying to give any advice, but this is an ACDF, anterior cervical discectomy infusion. You have a plate over the front. This is actually my favorite plating system. I'm not going to give any free press to the company, but if you direct message me, if you're another spine surgeon, happy to tell you, I really think this is one of the best plating systems. I've used way too many in my young career, but this one's pretty darn good. Again, not giving free press. And then you have these spacers or cages, we call them. I kind of hate the word cage because it's not, I don't know, cage just sounds like such a scary, aggressive term. I like spacers, but I don't like calling them replacements because it's not a disc replacement. It's a fusion. Technically, you're replacing the disc with these, but that is not a disc replacement. Disc replacement's a totally different device. So I just make sure that patients are fully educated. And that's kind of why I'm jumping on here during the workday, is just to kind of help educate patients, clear up misconceptions. I do telemedicines. I'm not trying to have this be an advertisement for telemedicines. You can direct message me and I can give you instructions on how to do telemedicines, where we do them from, and kind of go from there. But again, you can direct message me and I can get you set up for a telemedicine with my staff, but that's not the goal of this. I don't do epidurals. Okay, so going back to the loose screw, I did say doo-doo. I agree. That was funny. These screws can get loose. That's not extraordinarily uncommon. That doesn't always mean you need surgery, though. If the screw gets loose, it could be from a couple things. It could be maybe you had some weak bone or weaker bone than we hoped or thought, and this cage, I said cage, spacer cuts through the bone, alters the biomechanics, and then it's just that up and down movement that screw can get a little loose. Not great, but many times you still fuse in that spot, all good. The other thing that can cause a loose screw is if this locking device, you can kind of see there's something that goes over the front of that plate that locks into place, that could be defective or not cover it completely, or maybe the surgeon didn't turn it as much as they thought, or the screw pops over it. Not the end of the world, but the screw can back out from that. Again, that's not necessarily an emergency. You don't have to fix it. It's more so based on the symptoms, where it is that lumbar, is that esophagus? Totally different argument, but those are several reasons the screw could get loose. Usually it just means you haven't healed that area yet. So you would anticipate that happens in the first 3 months to a year. After a couple of years, you wouldn't necessarily expect that to happen, or you'd kind of expect it to be presenting earlier. What is this for? This is an ACDF. It's one of the ways surgically to treat spinal stenosis, but I'd really love to go over some of the non-surgical ways. Kind of going over some of the other non-surgical ways to treat. I see some of these questions coming in from Thomas Templeton saying, I had a 4-level lumbar laminectomy, L2 to L5. Now I need a long fusion. A couple docs want to do a 4 or 5 level fusion. A couple want to do a 7 or 8 level fusion. Well, Thomas, this is why people appropriately don't like spine surgeons. And let me tell you what I mean by that. And that's kind of why I jump on here as a spine surgeon here in Dallas, Texas, to try to just provide some clarity for people. Well, look, I jokingly say those hip and knee doctors got it pretty easy. You either need a new hip or you don't need a new hip. You either go through the front of the hip or you go through the back of the hip. You either go through the front of the leg or of the knee, or that's kind of it. So I'm joking. There's a lot more nuances there, but those guys got it, and girls got it easy. There's not many ways to fix issues with the hips and knees. Spine surgery sucks because there's so many ways to do it, and that is a problem. Just to be very clear, say you have something at lumbar 4, lumbar 5. Watch what I'm going to do here. So bone, disc, bone, lumbar 4, lumbar 5. If you need a fusion there for some reason, listen to all the ways you can do that fusion. You can do it through the front, an A lift. You can do it through the side, an O lift. You can do it more from the side, a lateral. You can do it lying down, that's prone. You can do it left side up. That's the more traditional way. That's left side up lateral. You can do it single position. So while here, then you can put the screws in. You can do it 2 position through here. You can do it open, big open incision. It's good. You can do split incisions. You can use augmented reality. You can do it you can do some factors endoscopically, but endoscopic's non-fusion. You can do it navigated. Oh, you can do standalone. You don't have to do screws in the back. My goodness, look at all those ways I just told you there. You don't even have to do a fusion. I guess if you weren't doing a fusion, then you can do just a laminectomy. So look, that's a lot of ways to just treat one issue, and that sucks. And that's why when you go see 10 doctors, you get 15 opinions, and that's why people appropriately don't trust spine surgeons or are confused or saying, I saw one spine surgeon, they said 3-level fusion. I saw one that said 1-level laminectomy for the same issue. That's bad. We, as spine surgeons, need to do a better job. But the good news or bad news, defining how you're talking about it, is just a lot of ways to treat issues. It depends on the technology you use. It depends on getting to know the patient. It depends on, how big of a surgery do you want to do. So, Thomas, that kind of goes back to your question. I don't know your case. I can't even give you too much medical advice, of course, but it sounds like if they just did a laminectomy to start, sounds like a good thing to start. They didn't start with the big fusion; they did a laminectomy, and now they want to do a fusion there. I don't hate that argument just baseline because I kind of like just looking at your comment. Sounds like they started with the less aggressive, less invasive, um, less negative effect approach of a laminectomy, and then now because of whatever's going on, maybe now they're saying I would do a bigger thing. In terms of the levels, if they're doing 8 levels, that to me, I don't have my big spine model here today. I do have some disc replacements though, so maybe I'll talk about these next. Is they will like this tool, is they're maybe doing the fusion way up in the spine, and that's better for degenerative scoliosis. Degenerative scoliosis. All right, my friend. Well, I spent a lot of time on that question. I appreciate the comments. I appreciate the likes and follows. Courtney, Sonia, thank you for the follow. Dominant, thank you for the follow. Let me go over a couple other things. I'm trying to get some of these questions. I see a lot coming in, so I apologize. Do I do telemedicine? Yes. I don't want this to be an ad for it. Just direct message me and I can give you stuff for it. Megan, thanks for the follow. Erica, thanks for the follow. Okay, stenosis help, non-surgical. So in terms of treating the stenosis non-surgically, really the two things I want to just emphasize today, it's buying time and also avoiding certain ridiculous things to avoid surgery. Let me kind of go over the buying time, and then I'll come back to what do I mean by avoiding ridiculous things, because you're like, what the heck does that mean? Again, appreciate the likes, appreciate the follows. So I'll be pretty quick here. On the buying time, that's where some people say, oh, it didn't work, but maybe it did. Buying time is steroid injections, calming down the inflammation. It is anti-inflammatories, calming down the inflammation. Most people, your stenosis didn't start overnight. It started over months to years. The exceptions are infection, trauma, tumor. Those things can happen fast. Fortunately, the majority of people, that's not what caused your stenosis. Most of y'all, the stenosis is from degenerative rubbing back and forth. It happened over months and years. Let's calm down that inflammation. And anti-inflammatories, injections, physical therapy has a great role. I support chiropractors for the lower back. I also support it if they're not, taking all your money, if they're just doing nice, appropriate things. If they're doing these crazy like stem cells or spinning PRP in their office and they don't exactly know what they're doing, they're just trying to take your thousands of dollars each time. I don't love that. But in general, I like chiropractors. I think they have a great role. Acupuncture therapy, cupping, we don't exactly know the science behind it, but if it helps you, then I'm okay with it. So that's some of the non-operative things I like. And that's what I mean by buying time. We just got to get you out of this flare up. Appreciate the like, appreciate the comment from Diamond, Chris, Shelly, and Tim. Those are all very helpful. And I'll get to some of those other questions here in a minute. So that's the buying time. In terms of avoiding ridiculous things, and that's a weird thing to say, here's what I mean by that. There are several doctors, usually it's in smaller towns, honestly, or they're not spine surgeons that offer ways to treat your spine that are minimally invasive. I'm doing all these quotes here because it's like, what are you talking about? One of those is it's kind of like the MILD, the mild procedure. Now, hear me out because I know it's a controversial thing to say. What they're doing in the traditional mild procedure, it's usually not a spine surgeon. It's usually a pain management doctor doing spine surgery. So that should be kind of red flag number one. It's a small incision. Hopefully, my God, it better be maybe like the size of. I'm trying to give you some perspective. If this is a phone, probably that big there, and then the back, they're just kind of shaving off the tissue that's here, the ligamentum flavum tissue. I don't love that because it's still a full-on surgery in a way. The only times I would love that is maybe if the patient's like super decrepit, they really just can't tolerate surgery. But if they're still getting the full anesthesia and all that stuff, that's still kind of the full risk of surgery. If a spine surgeon is doing that procedure, I have a little different thought. just because they know how to manage the complications of it. They know how to manage the outcomes if it doesn't work. I don't love the idea of a non-spine surgeon doing spine surgery. And y'all at home might think that is an obvious statement, but like it's not even to be surprised. It's happening as we speak all day, every day. Pain doctors who I support and I need and I like doing spine surgery. That's what I don't like. Um, the other thing is there's certain things out there where they do injections into the disc space. I saw such a nice lady and her husband yesterday. She is probably 75, could stand to lose some weight. She's been avoiding spine surgery for years and years. She has several things: spondylolisthesis, that's when one bone slides forward, severe arthritis, shooting down pain. And she's seen me as a last resort because she's seen multiple other doctors and tried multiple other things to avoid the rods and screws. And I know I'm saying that in a little flippant way. Rods and screws aren't bad when you need them. When you need them is several indications. That instability is definitely an indication. If I could share her images easily here, I'd show you. The reason I'm saying that upsets me is she saw a doctor who is a spine surgeon, I think, um, about 2 hours outside of Dallas. I'm just going to leave it at that. And she paid $17,000 for a certain type of injection. It's not stem cells, it's not PRP, into the disc space. And that was supposed to help her. And I just, look, I told her, look, if you got millions of dollars and you're doing great, then great, go for it. Probably fine. But there's not peer reviewed study in high impact journals to show that certain of these things help. They might say, oh, I had 20 patients, I did to 20 patients, and almost all of them did great. Well, fine. Most patients do good with time anyway. I'm not downplaying certain things. I just don't love the idea. I mean, it made me really frustrated that she told me she paid $17,000. They dipped into the retirement fund for something, and she says it didn't work a lick. Well, look, I'm not wanting things not to work, but if it's insurance covered, if it's Medicare covered, I don't like that still, but at least you're not paying your hard-earned money. $17,000 is a whole lot of money. And so it just kind of really irritated me that she was promised something and it didn't work. And she's just trying to avoid surgery at all cost. And that sucks. So I'll just kind of leave it at that. Maybe there are a lot of patients who do pay that money and they do great. And what do I know? I'm putting rods and screws in people. And, maybe if they just paid $17,000, they could have avoided it. I don't know. Either way, that's what I'm telling you in terms of the non-operative treatments for spinal stenosis. I really just want to emphasize, don't try to do ridiculous things. If it sounds like it's too good to be true, it probably is too good to be true. The other argument comes up about stem cells and PRP. It's a little controversial. To summarize it, I am not an expert on stem cells or PRP into the elbow, into the hip, into the knee. So I'm not commenting on that. There are many people who have done great with that. In terms of stem cells, PRP into the spine, let's kind of take a couple steps back. First of all, it's a bummer that it's not insurance approved. That means you're going to be paying thousands of dollars. I don't like that. And I don't like that necessarily. The other argument is, oh, you're a spine surgeon, so you don't want people to do that because it avoids spine surgery and you make money on that. That's actually a really dumb thing to say because I could do PRP next week if I wanted to. I could call the PRP rep, they could train me, they could put it in my office, and I could charge patients cash for something. I'd make more money doing something with less work. Instead of doing surgery on patients, I'm doing this, taking their cash, and then they might need surgery anyway. So when people say that doctors are only against it because they don't want to lose surgery, that's just not true. Doctors that do it make more money than doing surgery. And if it doesn't work, they still do surgery. So it's just a ridiculous argument to say the only reason spine surgeons are against it is because they don't want to lose business. That doesn't make any sense. I could do it next week. I will start doing it once there are good peer-reviewed studies in high-impact journals to say that it helps. The things that you also hear is, oh, I had a friend who did it and they got better. Well, that's great. I'm happy they did. I'm not necessarily trying to steer patients away from it. I'm just trying to educate you that you should do your own research on it. And you should ask, is this reviewed in spine surgery? Has it shown that it's helped? And look, if you have a ton of disposable income, if you're willing to spend $5, $6, $7,000 to get better, then I think that's a great role for it. There are many studies that also show that the steroid injections really help also. RFAs really help also. Those have the similar properties or the steroids do, to PRP. It's at best a very strong anti-inflammatory. Now, it's steroids versus PRP. Of course, PRP is a little better than steroids just because it's your own body. It's got anti-inflammatories. But in terms of the cash price or paying your insurance, that's why I do support steroids. It has some of the same effects. It's the anti-inflammatory properties. So again, I'm not necessarily anti-steroids or anti-PRP. I just think there's very clear ways to get better surgically and non-surgically. So going to a couple of questions I'm seeing, I agree there's about 2,000 people in the chat now. So I'm just trying to get some of those questions. I'm just going to reset for everyone who's new and joined. I'm a spine surgeon here in Dallas, Texas. This is where I was born downtown Dallas. Um, Grew up here. My family's from here. My wife's family's from here. This is where I've been practicing now for many years. Did my spine surgery training 10 years outside of Dallas. So kind of all over America, all over the world in a way, if you consider Miami a different part of the world. Back here, I do everything from the neck down to the pelvis, and I sometimes jump on here. Usually it's on the weekends, and usually it's in the evening just to go over different spine concepts. Today is obviously a Tuesday. It's a work day. It's during work hours. Normally I do surgery during this time, but one person didn't get clearance and the other person moved their case. And it's been kind of weird, cruddy weather here in Dallas, and we don't handle it well at all. So I had nothing to do this morning, unfortunately. And last minute. So I decided to jump on here, just kind of answer questions for patients. Can't give medical advice, but hopefully steer you all in the right direction or get you all to follow me. And then you can kind of keep learning things. Appreciate all the likes coming through. I see we're almost at 10,000. That's great. Very humbling. Not humbling, very flattering. I'll probably jump on here for maybe another 10 minutes and then I got to sign off and get back to my family. So it is kind of nice hanging out with my family today instead. Again, appreciate the likes, Tonya, Jesus, Beth, Mr. Crohn's, Gabriel, thanks for the live follows. Thanks for the shares. And let me kind of go over things. Sunshine, thanks for the gift. Don't send me any gifts. I'm not joking when I say I'm not doing TikTok to make money. Save your gifts and money for other people like in Africa. They're dancing, singing people happy birthday for money. Those are the people that really need it. I'm a spine surgeon. I don't need the money from TikTok. Not being rude, just save your money. I appreciate it. All right, everyone. So let me kind of jump on a couple more things from G Hammer. Thoughts on telomeres? I don't know much about telomeres except from what I learned in med school. I probably need to do a little more research on that just to be humble myself in front of y'all. So I don't know a lot about telomeres. What's my thought on degenerative disc disease? I hate it. It's tough because it's hard to treat. It goes bone, disc, bone, all the way down the spine. Degenerative disc disease is the following condition. It's when this disc space, either 4, L4, L5, or L5, S1, severely wears out. I don't love the term disease. It almost sounds like you have a awful condition. Sometimes most patients think it is, and I'm not downplaying that, but it's really at one or two of these levels starts to severely wear out, and that loses the cushioning in the disc space. Well, that then translates, if you lose some of the cushioning, it's like if you lose a lot of air in your tires, your shock absorbers, now being your facets in this car analogy, starts to take extra stress, and that hurts. There's not a great fix for it because there's not a great diagnosis for it. It's hard to prove it's just one level or two levels. Frequently, if it's just this one level, if you can prove with a clinical exam, injections, getting to know the patient, advanced imaging, that's one level, there is a role for just fixing that one level that's either disc replacement or fusion, a little controversial, and it kind of depends on your training, your institution. So there are ways to treat maybe a one level disc degeneration if you can prove it's just that one level. The things that people do great from spine surgery, both in an operative standpoint, but even in a non-operative standpoint, is when there's just one pinched nerve or spinal stenosis. The people that do bad from spine surgery in general are those where maybe the diagnosis isn't completely clear or if it's a huge surgery. And I've definitely had patients with that, and it humbles me and it makes me sad. But when it's just like a one level deal, a two level deal, and you can prove it's that, and you just fix that area, that's when patients do great. You don't need to fuse the whole spine. You don't need to decompress the whole spine. You just need to target that one level. That's also why some patients have a second or third surgery, is maybe their whole spine looks like garbage, but you're like, hey, your symptoms are very clear. Sacral 1 nerve, L5 nerve, maybe an L4 nerve, and you just treat that one area. Well, maybe over the next 6 months, a couple of years, the other areas start to wear out, and then maybe you need a second surgery at that second area. That's not to say that this first area failed or something like that. It's just to say you have continued degeneration of the spine. There's other arguments why you have a second surgery in the first couple months or years that could be related to that surgery for sure. I'm just saying that's one of the misconceptions about spine surgery. I've seen a couple of great questions go on here. I'm going to try to get to those pretty quick. Someone saying I look like Paul Walker. I appreciate that. I don't think that's true at all. Um, FAV, I don't know what that means. Trying to get some of these questions started. They're coming in. Please show us the back and front of the spine. Okay, I will. Sorry, I'm looking at some of these questions here. You should learn to do bone graft from an iliac tunnel under the muscle, vertical incision. Eric, wow, that's a very specific thing. I have to think about what you said, iliac. Direct message me what you're saying there, Eric. I have to kind of digest that. But harvesting bone graft from a patient, we can kind of talk about that. In general, if this is the spine, back in the day, and some people still do it, and that's fine. But I don't have a great model of it here. We have this pelvis and your crest. Well, a lot of times, what spine surgeons would do is they make a small incision over your butt, and they take out iliac bone crest. They scoop it out, and they'll put that into the fusion site. That actually is a great way to get a fusion. It really is. You get some of these stem cells that are your own. You get this good, nice bone, and it's a great way to get a fusion. But in almost 30, and you also do it in the front, the iliac crest in the front, and about 30% of patients, and this is in the traditional old way, big incision carving out. There's much better ways to do it now, but about 30% of those patients would get in pain in that area, and they'd say, "Ooh, that's the hardest part. That's the most painful area." And so, thankfully, with technology and better biologics, spine surgeons have gotten away from having to harvest bone crest from a patient. Do we still harvest bone crest from patients? All the time. Sometimes if there's like a lack of a healing, if the patient's high risk for not healing, those would definitely be indications we still take bone crest from that patient. But fortunately, we have different cage technology. See, here's a nice one here. Different cage technology. We have different biologics, and what biologics is like synthetic bone, things that stimulate bone growth. So we don't have to do that as much, but there's still definitely a role for it. So that might be what Eric was referring to. In terms of the new technologies we use, this right here is like let's see if it shows up. Mhm. I'll try to get this to show up a little better. This is kind of a cool technology. I don't think it's showing up that well, but you see it's like mesh. It's a very rough surface. I'm not going to give too much of a free shout out to this company, but they, as long as other companies have technology that allows, it stimulates bone growth. So when you do a fusion, you want the bone to grow, you want it to start growing in, and that's kind of a key part of the healing process. Sorry, my phone is going off. I am not going to be able to stop that. It looks like spam. Okay, perfect. That did stop it. So those are some of the arguments in terms of spine surgery, spine healing, kind of going over the different things. If you can use these special technologies such as the cages, that can help fuse the area and that helps avoid other surgeries. So again, I do appreciate all the likes coming through. I do appreciate all the follows. Tyler, Tanya, thanks for the follow. Darren, thanks for the follow. Kind of do end with one thing. It's kind of how we started. We talked about disc replacements. In general, trying to get this one not to fall off. I love cervical disc replacements. I would say majority of spine surgeons love cervical disc replacements. This is a cervical. This is a model of one, but this actually is exactly how it looks. Cervical disc replacement right here. Cervical disc replacements are great. We love cervical. We spine surgeons love cervical disc replacements. The reason I keep emphasizing the word cervical is it's just like a hip replacement and a knee replacement. They're two totally separate things, even though they have some of the same words in it. Two totally separate things. Cervical disc replacements do great for soft disc herniations that have not gotten better with conservative non-operative therapy. Or if you have like wrist drop, total weakness, you maybe don't have time to do the conservative 6 weeks of waiting. And that's something where you might benefit from getting a disc replacement before conservative therapy. But in general, I need at least 6 weeks of trying physical therapy, injections, anti-inflammatories before I would be too interested in doing a cervical disc replacement. A lumbar disc replacement, totally different beast. That's totally different things. These, you can even look at these. First of all, your neck is totally different than your lower back in terms of the weight and the stress. These sizes, sorry, the cameras were reversed on me. I do know my left and right. Totally reversed. So that's the whole deal, everybody. Totally different things. I see patients all the time, unfortunately, wanting a disc replacement, and I tell them no. I'd actually recommend. A lot of times, I recommend less. I recommend either a micro discectomy or a laminectomy. Like they don't need any metal in their body. But frequently, I say no. I know that 3 other spine surgeons told you need a fusion. I do agree with that statement. but maybe it's worth hearing it from someone else, someone that you've gotten to know through social media, you gotten to kind of trust through the social media process. There's definitely a role for that argument there. Okay, so everyone, so I am do have to run. I appreciate all the likes and follows. Has been very productive, a very good way to kind of share some of my expertise with y'all. I like to jump on here. Again, usually I'd like to be operating on a Tuesday, especially during this hour. Maybe I should go golf or work out or do something else for myself, but I do like kind of jumping on here, interacting with people that are having spine issues. Hopefully, you guys can all subscribe and follow and share. That kind of helps promote this to other people when you get those bigger numbers. Again, my background is I'm a spine surgeon here in Dallas, Texas. I do everything from the neck down to the pelvis. We have a pretty darn good telemedicine scheduling process where we get patients all the time from a telemedicine standpoint. Certain rules, of course, apply. And I'd just like to thank y'all for the opportunity. Man, it's funny as I'm signing out, I see that the viewer count is skyrocketing up. So, not sure what that is. I guess everyone's kind of really attentive right before I sign out. So, maybe with that, I'll kind of keep drinking the Kool-Aid and go over a couple more things. I just think another advantage of kind of reaching out on the social media platforms is you might see in the comments other people that have the same question as you or that were patients of mine. I can't confirm or deny they are patients of mine, but you can kind of, or patients of someone else, and you kind of ask, how was your spine surgery? What are things you would recommend? Because, I humbly will say I've never had spine surgery myself. So some of these questions in terms of what's it like that first day you get home, I haven't necessarily experienced. So that's kind of a nice avenue of the social media aspect. It's just a good way to connect with other people about some of the similar conditions. Kind of do a couple more questions. Chiari malformations. Chiari malformations are one of the few things I don't treat. I don't do too much of the brainstem apart from spine trauma. That's at the brainstem, but brainstem stuff, I sent that to one of my friends who wants to do that though. Josh saying, please answer my question. Josh, I apologize. A couple thousand people in the chat. I have missed it. How to determine if it's rotator cuff or cervical spine? That's a great question. Well, getting an MRI, step one, might be an obvious step, but you get an MRI of the neck and an MRI of the shoulder. If the neck is totally good, but the shoulder has pathology, well, then there's that. Now, say they're both bad. Say you got stenosis, tightening of the nerves in the neck versus tightness of the nerves there. That could be something. So let me kind of back up and answer this a little more formally. How do you determine if your shoulder pain is coming from the neck or if it's coming from the rotator cuff? Well, there's a couple things to do. First, I would get an MRI of both the neck and an MRI of the shoulder. If the shoulder looks bad and the neck looks good, it's probably your shoulder. If you have something where both the neck looks bad, as in a pinched nerve, and the shoulder looks bad, a clinical exam is one way you could identify if it's the shoulder. You could also get something called an EMG or a nerve conduction study to see if a cervical 5 nerve is involved. And another easy test you could do is a steroid injection into the shoulder. If that takes care of all of your pain, it's very likely coming from the shoulder. If it's both, say it takes away some of your pain, but you still have the shooting down pain, which one to treat first? Kind of depends on your spine surgeon. It depends on how much spinal cord compression you have. That might be something worth addressing first. It also is just a long discussion with both your spine surgeon and shoulder doctor, who should be colleagues and friends and kind of have the plan together. So, great question in terms of what to do first, the shoulder or the neck, if they're both. It is common to have both things going on. Fortunately, usually it's the shoulder that's causing your issue, and so we don't have to do it. Um, with that, I'll stay on for one more minute. I'm going to sign off at 11 on the dot, and we'll kind of go from there. Tips to manage the sciatic pain. Usually, a doctor could call it something called a steroid dose pack. An anti-inflammatory steroid dose pack is a very helpful way to do it. Anti-inflammatories, physical therapy, chiropractic therapy. I know chiropractors sometimes get a bad reputation, but hey, so do spine surgeons. So I think if you are going to use a chiropractic doctor, I would definitely ask your spine surgeon to recommend one. They should really know some of these non-operative providers, such as a chiropractic doctor. They're like at least 3 in the Dallas area I send to all the time. If anyone's in the Dallas area, specifically kind of the Dallas area and North Dallas, if you direct message me, I'm happy to tell you who they are. 2 of them have become pretty good friends of mine. I've sent, I don't know about hundreds, many patients to them. So I just trust them. I don't recommend the chiropractic doctors that are popping your back or putting traction on your neck. There's just not a great role for that. The things that they do well is deep tissue massage, acupuncture, cupping, They can do different forms of physical therapy, and they can also kind of listen to a more holistic approach. And I think that's helpful. I think there are many studies that show just having someone kind of listen to your issues, care about your issues, is therapy. And I know that sounds a little silly. It sounds a little placebo effect, but it's a real effect. And there are many studies that even show if a patient knows they're taking a pill and it's a placebo, it's a sugar pill, they still have clinical improvement for certain conditions. I can't remember what the condition was. I think it was migraines or headaches, but it's quite an interesting study where instead of doing a randomized placebo, they're just saying, hey, this is a sugar pill. There is no science here. Take this pill. And patients still got better. And the argument was there's probably something in our brain, just the way we're wired, that if someone knows you're in pain, they care about you, that helps. So pretty interesting things. What gloves do I use? I don't know the brand. It's kind of whatever the hospital buys. I go to like 4 different hospitals and they're all the same. So I'm not sure what gloves I use. If you told me the name, I'd probably recognize it. I'm sure there's probably only like 1 or 2 types of gloves. So um, I don't know the name of the gloves. I can see it. It's like a green label. So I'm not sure. Uh, in terms of getting second opinions, yep, I do those all the time. I think those are very helpful things to do. One of the things I would recommend in surgery, in spine surgery, let me say that again. One of the things I'd recommend before getting spine surgery is getting a second opinion. If someone's offering a multiple level fusion, it's definitely worth getting another person's eyeballs on it, brain on it to kind of look at the MRI, look at the x rays, look at the CT if that's there also, and see is this something that would benefit you, and also maybe it's another person just to go over what are the risks of surgery, what are the benefits of surgery, why should you do it now versus in a couple months from now. So that's kind of a key thing. I do definitely support second opinions, and that'd be a great way to do it. Well, everybody, I do have to go. I promise you, besides doing this, I have a social life and a family life and even a work life. So this was great. I enjoyed doing this. I have a telemedicine appointment here that was 2 minutes ago. I did lose track of time. So I'm going to sign off, talk to one of my good friends who I met a couple weeks ago, has a brewing surgery. We're going to go over some questions here, telemed. Nice guy from Plano, Texas. So I'm going to go forward and do that. I appreciate the follows, appreciate the shares. Comments are very helpful. And then, reach out to other people that are having similar issues. If you want to get a telemedicine appointment set up, please direct message me. I can send you, or my office staff will send you the template of how we do the telemedicine appointments. The number one thing patients don't do correctly is they get the MRI. Everyone's gone to an MRI center, they have their MRI, but they don't have their x-rays. They don't have their x-rays. Tommy, you said you never explained breathing, voluntary or involuntarily. That is actually so funny. You did ask that forever. Tommy, you're my new favorite person. Okay, well, such a ridiculous question. My memory of breathing from medical school, and again, I studied very hard, so I didn't have to study this stuff again, is that when you have a buildup of CO2, carbon dioxide in the body, that's actually what causes you to breathe. There's something in the brain stem, I forget what it is, that's seeing how much oxygenation and carbon dioxide's in the blood. So when you have too much CO2 in the blood, it creates the sensation. I think it's the phrenic nerve that pulls down your diaphragm that causes you to breathe. So it's actually not necessarily the lack of oxygen in your body; it's the buildup of CO2. That's why you'll see in the movies or even at home, if you hold your breath for a while, you can buy some time by letting out CO2. You can go and push it out. So when you see Tom Cruise swimming up from 2 miles down from a submarine, he's blowing out those bubbles. You know, I know we're so programmed to think that's what everyone does, but it's actually letting out the CO2. So, Tommy, that was a ridiculous question to ask me. And you should be shocked. I even know all of those details. But of the medicine things I had to learn in med school, that was one of the few things I remember. I cannot believe you asked me that question, but whatever. Funny question to answer. Hopefully, I wasn't too inaccurate. All of the pulmonologists that are watching this are going to be like, well, actually, but that's the answer there. So, with that, I am going to end this stream. I appreciate it. This was great. Love to go over some of these topics.